Craig, and welcome Mandy to come and speak to us this afternoon to talk about learning briefs, and I'll let Mandy introduce herself and take over from here. Thank you.
Hello, so I'm Mandy Craig and I work for the Children's Safeguarding Partnership, and I'm the Vulnerabilities Manager, and I'm going to be speaking today about the common themes identified in the joint case reviews in Sheffield. Because I've seen all the comments in the chat, can I just check that people can see that slide? Can someone speak and say they can see the slide, please?
Yeah, we can see it.
Right. Excellent, thank you. So most of my work in Sheffield is governed by the hidden harm strategy. This is in place to support services in recognising and understanding, safeguarding and improving the health and well-being of children and families living in households where there's drug and alcohol misuse, mental ill health, domestic abuse or harmful gambling. It doesn't mean that I know anything about all of those things. It means that the actual meeting and the strategy covers those to make sure that as a city, we're working towards supporting families in those situations. A key piece of that work, though, has been to ensure that adult services, especially adult mental health services, have been engaging in the whole family working system. So this is what I'm looking at really to talk about how we've engaged adult mental health as much as anything else. So since 2019, Sheffield Children's Safeguarding Partnership, together with the Sheffield Health and Social Care Trust, have been undertaking joint case reviews involving all the partner agencies. Lou Millington is the GP representative that actually sits in the review group. So the criteria for discussion is parental mental ill health. You can probably see that from the themes box to the side of the slide, which is explaining where the themes are, but you can see the parental mental health needs is actually got 10 of them. We look at how services communicate and work together. The better they work together, the more they communicate, the better the outcomes are for families, but also for the services themselves, in that they realise they are not having to be the only person that's actually supporting the family. In the 10 case reviews we've undertaken so far, there's been generally upwards of 20 odd services that have been involved, and I know that hindsight's a fantastic thing and we sit there with all the information so we can make all these judgments, but generally services haven't known that other services are involved, and I think that's one of the bits, and I know that it's already been spoken about in the two presentations that I've heard about the importance of multi-agency working. So what we do is we review what worked well and what else did we need to do or do differently to actually support the family. It also helps us identify any learning that can influence future practice, and this is a bit of what I'm hopefully going to be doing today. There's a learning brief that's written for every review, and these can be accessed via the Children's Safeguarding Partnership website, and we also have an annual learning lessons workshop which has a mixed audience of children and adult services and family services, and possibly around 100 people, though it's on next week and we've got 160 booked on, so it's a bit frightening really. So the most recent review, really, this was Family Q, and with the child named as Q. It was an incredibly complex family situation, possibly the most complex that we've actually looked at before. It involved two families, as mum and dad had separated, and both families had significant vulnerabilities, and there was also a considerable number of services involved. Interestingly, social care were involved with both families. Q herself was on child protection plan, but the safety plan from Children's Social Care was for if mum's mental health deteriorated or there was issues with mum in the household, for Q to actually go to dad's house. What wasn't recognised was that dad's house had similar vulnerabilities. They had substance misuse, they had mental ill health, they had domestic abuse, they had parental conflict. So really for Q, she was going from one house to another house, and it hadn't been recognised, that they hadn't looked at both families together to realise that actually the safety plan wasn't working and it was not keeping Q safe. However, there was very good communication and partnership working, which is interesting with the number of services involved. There was really good communication, but there were also areas that needed improvement. And these areas are the same ones that we see in nearly every single review, which was what we see in national reviews. So what I'm going to do with the rest of the presentation is just look at some of those areas to see what we can actually do to improve the situation. So, as I said earlier, all the families we review involve parental mental ill health. Many also involve substance misuse and domestic abuse. In some of the families, you could see how the different vulnerabilities were interacting, but not all the practitioners working with the family were recognising this or even considering it. For example, cannabis use impacting negatively on the parent's mental ill health, or the parent self-medicating through the use of alcohol, or a parent with poor mental health depending on the other parent for support, which may mask signs of domestic abuse such as coercive control. So it was about trying to get people to recognise how the parental vulnerabilities and the parental behaviours can interweave and actually have a bigger impact on the family in the household. So this infographic really illustrates some of the most vulnerable families in Sheffield. The ones where children are on child protection plan, and it shows the parental behaviour and experience is impacting negatively on their children in 78% of the families. So it's a considerable number of the vulnerable families in Sheffield. But if we look closely at the families where there's more than one vulnerability, I think we'd be able to actually possibly identify the other vulnerability. So it says that nationally is 0.9% where there's all three vulnerabilities is what's recognised, and in Sheffield we have 18%. It doesn't mean we have more cases where there is substance misuse, mental health and domestic abuse. I just think I'd like to hope that it's because we're better at recognising where there is those three vulnerable factors. So the following slides now will look at the common themes of joint case reviews. So event-based care. I think in all the reviews we looked at, we could see as professionals and services, we often consider each separate incident in isolation. We may not have time to look back at our notes or records, but for the family, each incident is building on the previous one, and slowly or quickly, the risk is escalating. So we need to recognise and consider the importance of historical information, involvement of services, and whether they indicates that the family have been struggling in this situation for a very long time, and the children themselves have experienced what's going on in the family for a long time. As GPs, you may already hold this information and should, wherever possible, include it in referrals so that the receiving service doesn't need to start right from the beginning again. We also need to consider what does it feel like for the family receiving care from a system of individual services, all with different agendas and different terminology. I know it's been said, and I'm going to be saying it throughout this presentation, but we all need to see the whole picture for the whole family. We have to understand we cannot see individuals. We have to be looking at both the parents and the children, sometimes at the extended family as well. So in terms of looking beyond the presenting problem, again, in many of the reviews, we could see that services only looked at what was written on the referral. They dealt with the situation that was there right in front of them. But what we need to do is we need to make sure we're looking beyond the presenting problem often, so that we can see what the parent is presenting or the child is presenting, what might be happening in the background. Whether this is illness, addiction, homelessness, criminality, we just need to be making sure we're not just focusing on what the parent's saying to us. And I think Dee was mentioning this in cuckooing as well. And also we need to acknowledge the complexity of past experiences and prior involvement and aim to gain a fuller understanding of how this may impact on what is happening now what's happening in the now. Making sure we understand that the person, whether that's the child or the adult, has been through rather than just concentrating on the behaviour they're currently displaying. So in terms of whole family working, hopefully this is fairly self-explanatory, but it's hopefully also illustrating the importance of seeing the whole family and recognise that sometimes we don't consider the parental behaviour in the context of other issues and stress factors of family life. We need to understand the lived experience of the child. That was a repeated theme throughout all of the reviews we undertook, as well as hearing the child's voice and understanding the role of the male caregiver and ensuring they are seen. In one of the reviews, the father was in and out of prison, so he was never part of any discussion or risk assessment, even when he was actually in the house and services were going into the house while he was there. Notice was not taken about the emotional impact on the children or mum when he was away and whether the family needed extra support. It was very much just about mum and the children, and dad was not there, even though when he was out of prison, he did a lot of support for the children, provided a lot of support for the children, sorry. So all reviews identified intergenerational trauma. And as you will be aware, being exposed to trauma, such as adverse childhood experiences, can impact a person's neurological, biological, psychological, and social development. Trauma can negatively impact on individuals and the communities they live in, and their ability to feel safe or develop trusting relationships with health and social care. Trauma-informed practice acknowledges the need to see beyond an individual's presenting behaviour and to ask, what does this person need? What's their story? Rather than considering what is wrong with the person. We need to identify and understand the impact of the parental behaviour on the emotional health and well-being of the children in the family. Is the family living in an emotional roller coaster? Is the parent able to hold the child in mind and prioritise their needs? And again, I know you've heard about intergenerational trauma. I know you've heard about professional curiosity, but it is, as Licky said, it is going to be a message I think that goes out in every single training you'll attend at the moment around professional curiosity, because it's integral to safeguarding and identifying risk of harms. It can be hard and it can be time consuming, but in any review you read, nationally or locally, the absence of professional curiosity is often a theme. We can easily slip into being overly positive or hopeful, which prevents us from addressing the why questions. Not questioning the circumstances which we are sometimes faced, for example, inconsistencies and mixed messages, refusal of accessing healthcare or support, the neglected state of someone's home, retractions or allegations of abuse, escalating health needs, repeated hospital attendance, or dropping from visibility. It requires us to basically think outside the box, to question our own assumptions about what is happening and looking at situations more holistically. It involves looking, listening, asking direct questions, checking out, reflecting on information received, and having systems that support practitioners to do this. GPs may be the only person cited on all the health needs of the family and instances of what's not brought. Basically, again, I'm going to say it again, we all need to see the whole picture. So coercive control, in many of the cases we looked at, it wasn't necessarily identified until the review that there's coercive control happening within the household. But there is still, I think, in many services. Oh, I'm really sorry, I'm going to have to just quickly answer the door. Sorry, I just knew that at any moment then the dog was going to start barking and everything was going to go wrong. So yes, so there's so many services. There's still an over-reliance on issues relating to physical violence as an indicator of risk. And the harm caused to children is often not understood and focuses on whether they have witnessed violence rather than on their experience of coercive control as victims in their own right. Without a shared system-wide understanding, joint plans and assessments are difficult and in worst case contradictory. In one review, agencies focused nearly entirely on the parent's mental health or the partner's mental health and his self-harming while he was in the house with the children. They didn't identify that he was also the perpetrator of domestic abuse. Mum herself had been assaulted as a young person and abused by previous partners. She had made suicide attempts and had problematic alcohol use. As a victim of controlling behaviour, she would also minimise the abuse and struggle to engage with support. She died by suicide following an overdose of prescription drugs and alcohol. 6 weeks before her death, she had retaliated in self-defence and was then heard at Marac as a perpetrator. Again, within this household, there was also the intergenerational trauma. Both mum and dad had had very abusive childhoods, and they were having to deal with that as they were moving forward, as they were trying to parent their own children. And then there wasn't enough consideration given to both their past trauma, the services that have been involved with them, but also recognising that mum was struggling and she didn't actually know who she could speak to. Right, so I'm sorry, this is in the wrong one. So I suppose this is just showing that this is a national review. You can I'll send the slides so you can see the reviews, and it's basically saying that all the things we identified in Sheffield or doing in our joint case reviews are also the same themes that are echoed in national learning lessons. Really, it's not anything new we were discovering. And so then finally, I suppose really in many of the cases we reviewed, as I've already mentioned, there were more than 20 services involved over multiple episodes. And sometimes the scattergun approach swamps families and they end up not engaging with anyone. We need to try and assess together and plan together wherever we can. We sometimes have an over-reliance on agency involvement rather than the impact it may be having. We need to regularly check with services we refer to about meaningful contact and engagement, sustained motivation and actual change. We need to keep checking whether the collective involvement is working to address the cause or just treating the symptoms. And I know Nikki mentioned the Sheffield Directory, and if you don't already know about it, it is an amazing resource that you can, as well as you can find things or services for children, for adults, for families. You can also translate whatever information you're providing for the family, you can translate it into the language that they use. At the bottom of that slide, it does talk about there's without, you don't need to book, but there's a session going on the 21st of November where they're talking about how you can use the Sheffield Directory and introducing people to it. And so that is all I'm doing. I think I might have even been early because I speak so fast. But thank you very much for listening.
Thanks, Mandy. That's been really insightful, and I think it builds on the pitch that we've already started to establish earlier on in the sessions. As you said, we are running a little bit early. We have got the opportunity. Would you like to take some questions, or
things are easy ones?
Yeah, if anybody's got any questions, we've got 10 minutes, so please feel free to put your hand up and I'll try and facilitate those for you. No, can't see anybody's hands going up, so everybody's obviously.
There's a question in the chat about the link, Mandy. Will the link work as it's in live?
It should do, as in the link for the training.
Jessica's asked that from Eckersfield.
Yeah, we can test that out, and if you just
it definitely links. It works on the slides, but whether it links if you do it while it's on the screen, I don't know. But you can access. You can easily go to it. But I could put it back up, and you could try it.
Okay. Anna, won't let you raise your hand, but you want to come in.
Can you hear me okay?
Yes.
I put it in the chat, but I was just wondering whether, I think one of the major barriers is that we all work using different systems, different IT, different electronic records. And so as a GP, I often have no idea what services are involved. These families, these parents often don't know themselves who's involved. Yeah. So is there any work on kind of how we can perhaps, bridge those difficulties, and what practical things can I do to try and find out who's already involved?
I suppose we could, hopefully for all the vulnerable families, we have things like Team Around the Family, don't we? And you'd hope that a GP would be the crucial person that they'd be inviting to the meeting. So in terms of you finding out whether other people, if the families themselves don't know, I think it would be more about other services contacting yourself. But we used to have Safety Net. People would probably remember Safety Net, but we got rid of Safety Net for the simple fact that it stopped people talking to each other. So I think wherever possible, health visitors, if they've got young children, generally do know. Health visitors seem to always know who's involved with the family. But I agree with you. I think one of the major problems we have in the city is we all use different systems. But in terms of social care and MAST, if people ever wanted to know if they were involved, you can email me and I'd be able to email you back and tell you straight away, which is something that I do for substance misuse, adult mental health and domestic abuse. So I also look at your referrals into the Safeguarding Hub, and I let Lou know about whether what the threshold's been and whether it should have been accepted or not. But so there is that opportunity. My email address is on the slide. If you needed to know something, just email me and I'll tell you. I couldn't tell you if it was a community services involved, but what I can say is that as Sheffield, we are looking at a Pathfinders service that will start. We're applying for some money funding at the moment, which will look at community and how we can better at the universal and the up to targeted, so the early help part, how we will be able to communicate and understand what other services are offering and whether they're involved with the family. So that hopefully, it all depends whether we get the money in January, but that is something we're looking at.
Thanks for that, Mandy. And if I can just add to that, this is a common theme around the information sharing from safeguarding adult reviews and domestic homicide reviews. And there's a review that's ongoing at the moment where the chair has made a recommendation around some of that. So what I will do, and I'll put my money where my mouth is today, but I'll make a commitment to go away and try and explore that, because it is a common theme. It's not an easy fix. It's really difficult in terms of system one and the accessibility. There's consent issues there around people, whether they want to share that information. So there's lots of nuances. And I think probably what the best thing to do is to look at what we've got, look at the difficulties, and then say, okay, these are the issues. We might not be able to fix them, but at least if we understand them, we might be able to know how to work around them. So that's my pledge for you all today. I'll take away and do that, and maybe at the next PLI event we might have some further information on that. Leanne, did you want to come in?
Can I just say, Kitty, the other thing that I'm trying to do is ensuring that GPs and all the other services get a copy of what Children's Social Care and MAST or FIS are putting as a safety plan, because I think if you know what the safety plan is, you're able to see what actually is recognised as safety rather than having to re-refer it in. So that's some of the work that we're doing currently at the moment as well. Sorry.
No, that's all right, and I'll tap into you because I think from an adult's perspective we need to look at the whole family. So yeah, thanks. Go on, Leanne.
I don't know if it applies to kids and children, but if we're saying that the GPs are the linchpin, people that everybody's involved with, it would make sense for other agencies to get in the habit of asking consent to share it with the GP, and then it would be sent to us and we would hold it. Even if we weren't looking at it all the time, it would at least be in our records to go back and search. at some point. And I think maybe all of us could get in the habit of asking people if they're happy for us to share information across services more regularly.
Yeah.
Certainly take away from this is making sure people who are seeing anyone with a mental health issue ask about children.
Yeah, thanks for that, Leanne. I think it's really important you touch on that information sharing, and it's something that I was going to reflect on at the end of the session. But you know, there is a consent to share information, but also the need to share that when consent is not given, and to what risk that means to those individuals. But we can pick that up in later reflections. Nikki Kelly, do you want to come in, and then I'm gonna let everybody go for a break.
Lovely. So just to add on what you've just said, Leanne, if you're looking at the threshold of need in the universal services, children's social care, where we tend to go to think that they've got all the jigsaw puzzles, they won't have it because they're at one end of the continuum, whereas you guys would be universal services. So actually, I absolutely applaud that suggestion. I've got another 2 points. There's something in the chat about TAF meetings and minutes. Ultimately, you need to go to whoever's leading your TAF to get the minutes, because it might not be children's social care, it could be a health visitor. So whoever's the lead for the TAF should be providing you minutes of TAF meetings. So seek that out. You should be receiving it. And the other thing I just wanted to bring to your attention is that information sharing systems across children, now unfortunately this is only children that are on a child protection plan or that have been looked after. They go into a system called CPIS, and that links in with children's social care. So it does, we do lose a lot of information sharing across other children. However, CPIS was for unscheduled appointments, so ED, out of hours, things like that, and then a notification would go off to children's social care to say that that child's attended nationally. Okay, that is extending. They are looking at a phase 2 on that, where that would include GPs, sexual health, dentists, etc. So actually CPIS might be a little bit of a step forward to sharing information across systems and services. However, we're still on the crux of it will only be children that are already involved in the child protection system or are looked after at this point. So I'll step forward, but not quite there yet.
Thanks, Nikki. And that brings us